to you today about an application that we've developed at the Institute. What I'm talking to you today about is really a work in progress. This is a project that's early in development. I would never imagine 3 years ago that I'd be here talking to you all. This was a research project that we developed for use at Indiana, and lo and behold, other schools expressed interest, and our path has pivoted about 9 times. So it's called the Regenstrief Electronic Health Record Clinical Learning System. We got to come up with a better acronym because that's just too much. The only disclosure I have is some of the work was funded by a grant from the American Medical Association as part of its Accelerating Change in Medical Information and Medical Education Initiative. So the project really started apropos to this MedX conference from the observation that like Stanford, like Vanderbilt, like Columbia University and University of Utah, Regenstrief and Indiana University has had an electronic medical record around for about 40 years. And unfortunately, we didn't use the electronic record to teach our students or residents. It was primarily used for clinical care. And Deb Litzelman, who's one of my collaborators, and I, a few years ago, decided that we would like to change that. And we had come up with a variety of projects to get students not only more involved in clinical care, but more involved in having the medical record help them with education. On the converse side, for our medical record at least, it's been developed really in the last 20 years by students and residents. We used to have what we called pizza lunches. So every Wednesday, we had pizza, which attracts all residents and students. And they would come in and tell us what was wrong with the system. And at least at Eskenazi Health, most of the teams were run by students and residents, so they were putting the orders in. They had supervision, obviously, from fellows and attendings, but the fellows and attendings weren't entering orders. So the students were really on the front line of how the system was working, and we took their recommendations and contributions very seriously. So the system was designed from that. But like I said, Dr. Litzman and I had gone down the path of involving students in different ways when the American Medical Association came up with their ACE initiative, and we were one of the lucky ones to receive one of the initial grants. So the idea was really to take our production system, create a system that would be used for clinical for curricular support primarily, and to teach some clinical points as necessary. So what is it? It's really a little quick cartoon. Shows we have a shrunken down version of the production clinical EMR that we're directed toward teaching. And we've also developed a database of about 11,000 patients from Eskenazi Health, who has about 1.8 million unique patients. We use a staging system to misidentify data and synchronize data for use in the teaching EMR patient database. It's about 10,000 patients. We picked that arbitrarily because that's the lowest number of patients you need to certify for as an accountable care organization. One thing I want to mention about the misidentification process, we thought that maybe we'd go through 300-400 text reports, and that would be good enough to populate the database. Well, it turns out that for 1 year, for 300 patients, they generate around 33,000 text reports. So obviously you can't do that manually. So we've worked for the last 3 years to develop algorithms to misidentify these patients. Now it's really easy to de-identify, and I just want to mention this subtlety. It's really easy to de-identify text reports of patient and provider information, but then you're left with a CIA report where everything's redacted except for prepositions and pronouns. So that's not obviously very valuable or very helpful in education. So the hard part really is to make these records readable and to replace real personal identifiers with fake identifiers. So the other way we use the system to support curriculum is to manipulate data. So in this slide, the slide's meant to show that it's really hard to pick a patient who in the next 6 months is going to have 5 hospitalizations or 5 ED visits or 2 hospitalizations, 3 ER visits, and 7 outpatient visits. But it's really easy to pick patients in the past that fill that criteria. So what we do is time shift the medical records or the notes for each patient so they look like they're contemporary. Another way we manipulate data is to be able to clone patients across a class or across a practice, or in this case, provide each student with their own quote-unquote own patient. So a patient with heart failure or sepsis. One of the interesting twists and turns is that the system, the value of evaluation for educators. So we basically key log students as they're on the system, so we know what they're doing exactly. So the curriculum teams can go then and have the system record what the learner does or what the student does, and compare what the student does to what actually was performed or provided for the patient by the real medical record. And if you look at the delta, this is a complicated slide. I apologize about this, but if you look at the delta between what the student did and what's considered ideal by the curriculum team, this is potentially a basis for a grade. Right? And if you look at the delta between what the learner did and what was actually done for the patient, that could be it could be a grade. Also, it could be the focus of a discussion about the multiple ways to get through patient care. So also on the evaluation side, just like we can do clinical trials, so the system can pop up questions about, in this case, diabetes medicine, give us some more information about this patient so we see if they qualify for the study. The system can also pop up questions to a learner. So, Dr. Jones, it's an interesting order for, this 3rd generation cephalosporin for a patient with viral bronchitis. Why did you do this? The idea is that we could provide information to evaluators about how students are making decisions, not based on speculation on how they made the decision, but potentially about the real reason why they made that decision. Another interesting aspect of the system is it has real-time NLP, so natural language processing. So what the system does is it looks at every 5th letter that's typed in by a provider or by a student in this case, and tries to pick out clinical concepts. So again, if you recall, the system was designed by physicians and improved by physicians for better or worse. But as physicians, we thought it was dumb that in the medical record you have to say what you're going to do, and then you have to go order what you said you were going to do. So this functionality was installed to avoid that duplication of effort. So in this case, the provider said for diabetes, patients do for an A1C, an ophthalmology consult, and electrolyte. And the system says, hey, look, it looks like you want an A1C, you want an ophthalmology consult, and electrolytes. And all the provider has to do is click on these things to order these for this consult. What's really interesting is our first iteration is we put these orders in automatically for the providers, but they freaked out, said 1984, you guys are spying us on that. So we had to step back and go to this intermediary step. But if you think about this, if we combine this with the ability to pop up surveys or use our clinical decision support infrastructure, we could see what a student, we could spy on a student, see what they're typing in, and then return questions or comments on what they're putting in the system at the time they're putting in the system. So we know, thanks to our friends at Vanderbilt, we know where you are in the note. So if you put, for example, here, if you put colonoscopy right here, the assessment and plan part of the note, the system knows that it's an order. If you put a colonoscopy in the subjective part of the note, it'll pull in the last colonoscopy result or the date of the last colonoscopy if the provider wants that included into the note. So in the educational teaching kind of mode, if a student were to type in the social history of smoking, and then neglected to put anything about smoking cessation in the assessment and plan part of the note, and if that's part of the objective for a particular lesson, an alert can fire saying, hey, this patient's a smoker, you neglected to include that as part of your plan, is this an oversight, or try to find out why students are making decisions. So the other, this slide is meant to show that the system can do formative assessment. So those alerts can fire off of students' actions for a particular session, or it could be linked to data that the student entered in a previous session. So the use case is a patient who, a student who wrote for aspirin for a patient who was admitted with pneumonia but had coronary disease, but missed writing aspirin for a patient who was admitted for a heart attack. Since the system, we record all this information, and if the curriculum team thinks it's important, we can link the fact that they wrote aspirin previously and they missed aspirin in this case. Again, ask critical thinking questions. Why did you do this in this case? So that case. So another interesting aspect of the system that was built into the clinical system that we ported over to the education system is this ability potentially for what we call collaborative documentation to be used for interprofessional education. So if you get on most commercial systems, if I get on to the system and a student tries to get onto that same patient in the same system, you get a box that pops up saying, hey, Blaine's in the system, come back later. Right? Well, being an academic medical center, we have teams of an attending, a senior resident, a couple of interns for medical students, a pharmacy student, an oral surgery student, maybe a nurse practitioner, maybe some nursing students, right? So there's these huge teams that are caring for patients. And we thought it was really inefficient to block one member of the team out, allow one member of the team to block everybody else out, because you can't get your work done. It's sequential work. A lot of the work in real life should be done in parallel. So we allow multiple users into the system at the same time, and there's warnings that pop up depending on what everybody's doing, just to make sure that the patients are safely taken care of. And then there's a box that pops up talking about which allows team communication. So this is being used for IPE, right? So you can have a nurse at the nursing school and a medical student at home, and our College of Pharmacy is in a different city. So the pharmacy students can all log on to the same patient at the same time and see what each other is doing, and also communicate through this chat function. It's interesting for the production system. The legal team would not allow us to record this stuff because it's discoverable, right? But for educational purposes, there's nothing legal that we've faced so far, so we are recording it. This is going into part of the evaluation for the IPE teams. So one of the steps we are working on right now is the thought of gamification. So there are many ways potentially to get from point A, where a patient presents, to point B, which is the optimal outcome. And since, again, we are tracking students pretty thoroughly or completely on what they're doing within the medical records, we're toying with the idea that we can assign scores on the quality of care they delivered by the processes and by the entries they're making into the system. So here's the team. We couldn't do it without them. There's a webinar if anybody's interested on how the system's being used at Indiana University and the University of Connecticut. Like I said, we've had to pivot this system quite a bit. It was designed for Indiana University. It's now at 5 medical schools. It's at the University of Southern Indiana, which is interesting because they don't have a medical school. They have a nursing school, an occupational therapy school, a radiation technology school, and a school for health information technology. It's being used in public schools of public health, and we've had interest from athletic trainers and all kinds of folks that don't have access to an EHR at this time. So this talk usually takes about 90 minutes, so I try to compress it, but you have my email address right there. Feel free to contact me. I love giving this talk. Entertain any questions. Thanks.
2 questions.
Two.
One is,
Yeah. Yes. Right. Excellent question. Excellent question. Yeah. So one of the things I wrestle with is we're teaching students to use EHR, right? 58% of doctors don't like their EHR, right? And I don't think our production EHR is any different. It may be a little bit slicker than some of the commercial guys, but basically we do the same. So we're actually overhauling our interface now just to simplify it for the students. So, because we hear the same complaints from our students that we hear from clinicians. But, you know, our secret motivation, the motivation of the Regenstrief Project, IU, the AMA, all the folks that sponsor us for, not only to teach students how to care for a patient with an EHR now, these kids what they should expect from an EHR. Because they're going to be the ones, they're going to be the change agents, right? EHRs as they exist right now probably aren't going to be here 5 or 10 years ago. It's not sustainable. Right? So many of the users hate it. Right? The fastest growing user of Epic is scribes. Why do you have to have a scribe if it's so easy to use? You have to have a scribe between you and you. Yeah.
which is,
Right.
you're trying to be
Right. Right.
so on and so forth.
Right. Absolutely.
Can you comment on
So we don't, right? You can't do it through this model. Again, this is the reason why we change. Things need to change. I agree with Dr. Elder completely, right? Technology we're on an increasing curve of technology interference, the doctor-patient relationship, and we should be on the other side, right? No reason why we can't have bedside technology getting done, getting kind of stuff done, right? We're asking physicians to be, data entry and stuff that not really, they're really expensive data entry folks, right? Does not make sense, individually or systematically or systemically to have. Yeah, right. No, I totally agree. I think that's the way they're going. Their voice recognition, that's great. Yeah. That's a great question, right? So for the whole, this is a tool, right? This is a tool to support curriculum. We don't see this as, you know, a tool to develop education. What we expect is the education to take place over here, and as you mentioned, the collaboration to take place within the, hopefully the principles that are learning and the educational curriculum be collected over here. That yeah. Right. So it's this all this work's been run through our IRB. We can painstakingly, and when we side on the side of protecting patient and provider identity, in terms of our algorithms to misidentify the text reports, identify somebody. I mean, it's always, I think the biggest risk for re-identifying or reverse engineering is what you actually know somebody. You're actually taking care of that patient, right? With the same profile. Now, there's going to be a huge question about misidentification once genomics is available. Because, as you all probably know, 3 SNPs and you know somebody. So we have to face those problems as they arise. But yeah, I totally agree. But we do things, you know, so even within the patient database, we do stuff outside of the misidentification process. If there are less than 100 patients with a certain disease process, they're excluded. If the patients are over 90, they're excluded. Patients have had more than 20 admissions in the last 3 years. They've had, you know, more than 50 ED visits in 5-day interval excluded. So we try to do the best we can to make sure those folks are protected. Again, you know, this is an education product or application, not a clinical application. So we don't, you know, especially at the undergraduate medical education level, you don't have to teach us either. Fine to talk about them, but I think most of the classes are around, lessons are around common. Thank you.